Hi, everyone. It's Dr. Linder again. We are going to cover the facial muscles, some of the main facial muscles today. We'll look at some of the neck muscles. We'll cover a little bit of the torso. So I want you to understand the difference of what's happening in the torso and the chest, as well as the upper back and the abdominal area. We'll cover a little bit of the eye and the sarcomere. Okay, so let's start with some of the muscles of the face here. Now, what we have right here near the frontal bone, right? There's a reason why we do osteology first, and then we do muscles, because muscles attach to bones. When muscles contract, they contract at the sarcomere, which is the functional unit where you'll review the actin filaments and the myosin. Those are the contractile proteins. Actin and myosin can shorten or lengthen. They can shorten and lengthen. When they shorten, we call it a concentric contraction. When they lengthen, we call it an eccentric contraction, okay? So here is the frontalis muscle, named after the bone that it's near. On the back side, you can just see a little bit of it back here. We'll see it in another view, is the occipitalis. So you have the frontalis, occipitalis, auricularis, and then deep to that, we'll see on another cut, we'll have a temporalis, okay? So you have a frontalis, occipitalis, auricularis, that moves the ear, like that. Can you see that? Okay, so that's the auricularis, and deep to it will be the temporalis. If you look around the eye, right here, going around the eye, that's the orbicularis oculi. That helps to close the eye. Here is the levator labii superioris. See if I could zoom in on that a little bit. Levator, to elevate, labii, lips, superioris, it's above. Now, antagonistically to that, right, if there's a levator labii superioris, there's a depressor, right? The opposite of levator is depressor. The opposite of superioris is inferioris, and labii or labii means lips. So that one's down here. So this one can raise the lip up like that, like Elvis. And then depressor labii inferioris can depress the lip or bring it down, as does the depressor anguli oris down here. Like you had an orbicularis oculi going around the eye, we have an orbicularis oris that goes completely around the lips. The risorius, that pulls the lips this way, right? It's not frowning, it's not lifting it up, it's pulling it back that way. That's the function of the risorius. Superficially, there is this platysma muscle, right? If you do that, that's the platysma. And then here, going from the sternum and the clavicle up to the mastoid process is the sternocleidomastoid. In this case, it's the right SCM, and the right sternocleidomastoid, when it contracts, it rotates the head to the left. When the left sternocleidomastoid contracts, it will turn the head to the right. Okay, and that's because if we look at origin and insertion, the origin is the sternum and the clavicle. The insertion is on the mastoid. So when the origin and the insertion move closer together, that's a concentric contraction that creates left cervical rotation. Eccentric is when the origin and insertion move further away, where it elongates. Okay, so those are some of the main muscles that we see on this first slide. Let's move on to the second one. We'll take a close-up look at some of these other muscles. You know, here's the jaw, right? Here's your parotid gland. Right here in the circle is what we call the trumpet muscle, right? If you go like this and you blow air out and your cheeks puff out, that is the buccinator muscle. That's a little bit deep here in the circle. Just anterior to the parotid gland, we have the masseter muscle, which is one of the 4 muscles of mastication. Temporalis is one. Mastication is chewing, right? See, when I bite down, that's the masseter. Here, when I bite down and my fingers move, that's the temporalis. So those are 2 of the 4, temporalis, masseter. And I call them time muscles, T-I-M-E, temporalis, T, M is masseter. So we've already done these 2, T-I-M-E, temporalis, masseter. So what's the I and the E for? The I and the E, I is for internal, E is for external. Well, in internal and external what? Internal and external pterygoid, P-T-E-R-Y-G-O-I-D, pterygoid. The pterygoids, if you remember back to osteology, when we took the skull, and the skull was turned upside down, and you could see the magnum foramen. Near the hard palate, there were these 2 processes called the medial pterygoid process and the lateral pterygoid process. The medial and lateral pterygoid process is the origin for the medial and lateral pterygoid muscle. And remember, the other name for medial is internal, and the other name for external is lateral. So the internal pterygoid and external pterygoid are also known as the medial pterygoid and lateral pterygoid. But for the purpose of the mnemonic time, T-I-M-E, the I and the E is internal and external. So you got temporalis, internal pterygoid, masseter, and external pterygoid. Those are your muscles of mastication. Those are the chewing muscles. The temporalis and masseter are going to shut the mouth, clench the teeth. The internal and external pterygoids deviate the jaw side by side. So when you chew, you just don't chew like this. You go side to side. So those pterygoids are involved with a lot of TMJ dysfunction, temporomandibular joint dysfunction. I treat a lot of these TMJs, especially they have to go intraorally with a glove into the mouth behind the last tooth, because that's where the lateral pterygoid attaches, and you can really get into that muscle doing release in the mouth. And it really changes lives when you can treat a temporomandibular joint dysfunction, but it has to be caught early on. If you wait too long, it starts to distort the joint itself between the condyle of the mandible and that fossa, the condylar fossa that makes up the TMJ joint. All right, so we have the mentalis, which is here. Remember, you have the mental foramen, those 2 mental foramen. So right there, you could see a little bit of the cut mentalis. 2 other muscles I want to point out. They're not labeled, but they are important. So here's the zygomatic bone. Right here, it's hard to see the number. I can't tell if it's like, I don't know, 30. It looks like a 3 and an O, but it looks like it may be too much. Maybe it's an 8. Maybe it's an 8A or something. So this one here is the Zygomaticus Minor. And then this one here is the Zygomaticus Major. Zygomaticus Minor, Zygomaticus Major. We will see, especially when we do the rhomboids, rhomboid minor and major, minors are always above majors. In this particular case, Zygomaticus Minor is above Zygomaticus Major, superior to it when I say above. So Zygomaticus Minor, Zygomaticus Major, here's the buccinator, here's the Mentalis, and then here's the Mentalis. The nasalis is right here. It's not labeled, but it's called the nasalis. The nasalis. There's the auricularis again to move the ear. Right there is the sternocleidomastoid with the superficial platysma muscle. Now here's the temporalis, right? It's a lot larger than the auricularis. Here's the sternocleidomastoid. There's a little bit of the masseter muscle that is cut. But here you can see the temporalis. Here's the belly of the muscle. And then you can see it comes right underneath that zygomaticus arch. And then it inserts right there on the mandible. So it helps you chew. And the masseter is here. It's at the angle of the mandible and it's just cut. Sternocleidomastoid, you could really see the two divisions at the origin. Here's the sternal division right there at the tip. And then here's the clavicular division. And then there's the mastoid process. So it's called the sternocleidomastoid. What we can see on the posterior side here is the trapezius. That's the trapezius. Now, here's what's wild. The trapezius and the SCM embryologically were one muscle. And then what happens is as the bones grow and the clavicle gets longer, right? The strut bone gets longer, the muscles separate. So the SCM and the trapezius become two separate muscles with two different functions. Okay, there are some deeper neck muscles here that we will get into, like the levator scapula and some of the splenius muscles and the scalenes. These are three important scalene muscles here. The scalenus anticus, medius, and posterior. These are the brachial plexus. Those are the nerves, which can get compressed by the scalene muscles. And then you get numbness and tingling down the arm. It happens to some people when they sleep on their stomach with their head turned, and then they wake up and their fingers are numb and tingly. It's usually the scalenes that are doing the compression. Okay, so here's the trapezius muscle, here's the sternocleidomastoid, and we already went over the masseter muscle. From the front view, here is the levator labii superioris, and then adjacent to it, there would be the rhomboid minor, and then that would be the rhomboid major. And there's the orbicularis oris, up here's the orbicularis oculi. There's your platysma. And then superficially, even though some of these are shoulder muscles, we can still see it here. This is the pectoralis major. You can see there's this little tab there because that actually pulls off and we can see what's deep to it. And if there's a pec major, deep to it will be a pec minor. Here is the deltoid, but when we do the shoulder, we'll see the deltoid has three divisions. Since we're looking at this at the anterior view, this is the anterior deltoid. On the side would be the middle deltoid. And on the posterior side, which we can't see because we're looking at the model from the anterior, would be the posterior deltoid. And those three divisions move the shoulder in different ways. The anterior division moves the arm anteriorly. I'm trying to see if you could see me here. So the anterior division here moves the arm anteriorly. The posterior division moves the arm posteriorly. The middle division moves the arm into abduction of the shoulder. So the anterior delt flexes the shoulder, which I should do in this direction. So the anterior deltoid flexes the humerus or shoulder. Posterior deltoid extends the shoulder. The middle deltoid abducts the shoulder. Okay. The pectoralis major adducts the shoulder, adducts. When the shoulder's here in an abducted position and the pec major contracts, it brings you back to midline, which is adduction or adduction. Okay, so deltoid is named by its shape because it looks like the delta, and that's how it kind of converges. It starts off wide and inserts on the deltoid tubercle on the humerus. Let's look at the back side. Now, I want you to focus on the right side first. Now, there's a large muscle here called the trapezius muscle. So here, these are the upper fibers of the traps. Here are the middle fibers of the traps. Look at the direction of the fibers. And then here down below are the lower fibers. You have upper fibers, lower fibers, and middle fibers of the trapezius muscle. This muscle on the right is a superficial muscle. If we deflect it away and back, it allows us to see what's on the left-hand side of the spine in this model. Okay, so the trapezius is on the right. We peel it back, and now we could see the splenius capitis here. You could see the splenius capitis right here. And anterior to that is the levator scapula. When you look at the word levator, it sounds like elevator. So the levator scapula is going from the C1, C2, C3, C4. So C1 through C4 transverse processes as the origin, and it inserts on the superior angle of the scapula. So when the origin stays still and the insertion moves, it shrugs your shoulders, right? Even though the humerus is moving, it's coming along for the ride. It's the scapula that's actually elevating, right? Because this levator scapula attaches to the superior angle of the scapula, so it elevates it. Now, remember before when I taught you the Zygomaticus Minor and Zygomaticus Major, I said minors are above majors. If you look here from the spine to the vertebral border of the scapula are the rhomboid muscles. So here's the rhomboid minor on top, and then here's the rhomboid major inferior to it. So from C7 spinous process and T1 spinous process to the medial border or vertebral border of the scapula, that's where the rhomboid minor goes from and goes to. So this is the origin, C7, T1 spinous, to the vertebral, aka medial border of the scapula. Inferior to that, from the spinous processes of T2 to T5 to the vertebral border of the scapula, is the rhomboid major. Now, if you look at the angle of this muscle, it's a little bit different than the middle traps, right? The middle traps is horizontal, but the rhomboids go on this diagonal. And the direction of the fibers give you a hint into the direction it's going to move the bone. So if we look at the middle fibers of the traps, it goes from the spine to the scapula. It's going to pull the scapula straight to midline. When the scapulas go straight back to the spine, to the midline, we call it scapula adduction. So if I were to stand like this and pull my shoulders back, my scapulas move to my spine, that's scapula adduction or scapular retraction. When I round my shoulders and pull them forward, my scapulas move away from the spine, and that's called scapula abduction, abduction, or protraction. So that's what the middle fibers of the traps do. The rhomboids can adduct as well, but because the direction of the fibers, if my hand is the scapula and the direction of my fingers are the rhomboids, well, remember, this was the middle trap, so it pulls this way. The rhomboids go in this diagonal. So yes, it pulls in, but it also will rotate it as it adducts. So it adducts and it downward rotates. Downward rotation is when the glenoid cavities or glenoid fossas point down. That's downward rotation. When the glenoid fossa or cavity of the scapulas rotate up, that's called upward rotation. Okay, So both rhomboid minor and rhomboid major adduct the scapula, and they can downward rotate it as well. Now, with the trapezius muscle dissected away, if you look on the right-hand side, we can see the spine of the scapula, but we don't see what's deep to it. On the left, remember, we peeled back the trapezius, so not only can we see the rhomboids, but we could see two rotator cuff muscles. Now, we will be covering these again when we do the shoulder, but above the spine of the scapula is the supraspinatus muscle. Below the spine of the scapula is the infraspinatus muscle. So you have supraspinatus, infraspinatus. One is above the spine of the scapula, one's below the spine of the scapula. The supraspinatus abducts the shoulder, and the infraspinatus externally rotates the shoulder. Make sure you watch my video on YouTube that goes over the ranges of motion as well, okay? If you haven't subscribed to the videos, go to YouTube and just type in Nutrition Chiro Doc. That's my channel, Nutrition Chiro, C-H-I-R-O, Doc, D-O-C, and you'll see a whole bunch of videos there. Okay, so now that we've covered those, let's go and let me just, what's the next thing I want to do? Let me get into, yeah, let's go here. And now I want to show you the same muscles, but just on a different model. And again, these are all labeled for you. So you can see the frontal belly. Well, frontalis is how we learned it, but it's the frontal belly of the occipitofrontalis, because the frontalis is here. And then there is this aponeurosis, this broad flat tendon that goes back, 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 and then attaches to another muscle called the occipitalis. So they call it it is the frontal belly of the occipitofrontalis. On the exam, for simplicity, if you're ever asked this, you don't have to write frontal belly of the occipitofrontalis. You could just say frontalis. Here's the orbicularis. And by the way, the connection between the frontalis and occipitalis, it's called the epicranial aponeurosis, because an aponeurosis is just a broad, flat tendon. Okay, let me see what else we have here. Let me just bring that back. Okay, here's the orbicularis oculi. Here's the Zygomaticus Minor, which is here. And then here's the Zygomaticus Major, which is here. Remember, minors are above majors. Here's the deep buccinator. Here's the masseter, which is in front of the parotid gland. Here's the rhizorius, pulls you back this way. Here is the levator labii superioris, right there. Here's the nasalis, going this way. It's not labeled, but that's where it would be. Here's the orbicularis oris that goes all the way around the lips, superiorly and inferiorly. There's your mentalis that's cut. Here's the depressor anguli inferioris and depressor anguli oris. There's your sternocleidomastoid. Let's go back one. Let's look at this one here. Again, we could see the orbicularis oculi, orbicularis oris. There's your mentalis. Here's your levator labii superioris, right there. And then here's your depressor labii inferioris, which is here. Depressor anguli oris, rhizorius. There's a close-up of the buccinator. That's your trumpet muscle. Here's your Zygomaticus Minor, Zygomaticus Major. Let's go back one more. I think there's one other image from the side view. Okay, this is a little bit easier. So here's the frontalis, and then up here is the epicranial aponeurosis. And then on the posterior side would be the occipitalis. There's a good view of the masseter, one of your muscles of mastication, and then anterior and deep to it is the buccinator. Here's your beautiful view of the sternocleidomastoid. That's the upper fibers of the trapezius. There's your splenius capitis. Okay, let's go back here. And now what I'd like to do is cover some of the odd muscles and some of the things that were, maybe I can clearly show you a few other things. Now, I have a video on the sarcomere, and just watch that video from YouTube, okay? Now, the sarcomere, this is an entire model of the sarcomere. If we look at A, this right here happens to be the functional unit. The sarcomere is known as the functional unit of muscle. And that's where you have these myofibrils that are actin and myosin, and they interact with one another. And you'll learn about the physiology of it in one of my other videos, or you'll learn about it in lecture as well. But actin interacts with myosin because myosin has these heads, and these heads attach to the binding site on actin. But the binding site on actin is typically covered by a regulatory protein known as tropomyosin. And tropomyosin covers the binding sites, and something holds it in place called troponin. So troponin and tropomyosin are these regulatory proteins, and what removes them or translocates them is called calcium. When calcium is released, it's like the staple remover, right? Troponin is the staple that's holding tropomyosin in place, covering the binding site on actin. So calcium pulls out the troponin, the tropomyosin shifts, and now these binding sites on actin are open, and myosin heads can attach to it and make it contract and shorten. Okay? And this calcium happens to be stored in the sarcoplasmic reticulum, and I'll show you where that is. So this right here, this general view of what I'm pointing to here in A, that's the sarcomere, okay? When we rotate it and we look at it deeper, now we can see why skeletal muscle is called striated. You can see all these striations. There is a nerve we could see here. This is an axon, this yellow right here. The yellow structure here is part of a nerve called an axon, and it's myelinated, right? This here is called a myelin sheath that's produced by a Schwann cell. This myelin sheath is nothing other than this fatty substance. It's made up of cholesterol, and it protects and insulates your nerves. So it insulates this axon. Okay, so this is myelin. This is the axon. And you can see that this nerve is going to attach to the muscle. How else do muscles contract? They have to get their messages from nerve. So where the nerve and the muscle meet, that's a junction, and it's called the neuromuscular junction. The neuromuscular junction. So what this is pointing to, this letter A, is the gap between the nerve and the muscle. And that space between it is called the synaptic cleft. The synaptic cleft. So it is the junction between the nerve and the muscle, the neuromuscular junction. And it's also referred to, the gap of that is the synaptic cleft. one of the layers, remember when we did muscles, there was an endomysium, there was a perimysium, there was an epimysium, right? Endo, epi, and perimysium. In the nerve, there's an endoneurium, there's an endoneurium, a perineurium, and an epineurium. In muscles, there is an endomysium, a perimysium, and an epimysium. So this one closest to the inside here, this is the endomysium, the endomysium. This layer is called the sarcolemma, not the sarcomere, but the sarcolemma. It has two M's. This structure here that looks like this meshy network, that's the sarcoplasmic reticulum. And the sarcoplasmic reticulum stores calcium. And that's what releases the calcium into all of these myofibrils deeper, actin and myosin. Remember, when the calcium is released, what ends up happening is it removes troponin, the tropomyosin shifts, and now these binding sites on actin are open for the myosin heads to latch on and create the sliding filament between actin and myosin. So you have this action potential or nerve impulse, if you would, that travels down the nerve and it hits the muscle. But what happens at the end of this nerve, at the end of the axon, which is called the axon terminal, there's a neurotransmitter that is released. And this is important for neuromuscular physiology. That neurotransmitter that is released is called ACH, or acetylcholine. And the acetylcholine is released by the axon terminal, and it starts to move into the synaptic cleft. The ACH is going to now move from the nerve side into the cleft, and it's going to move into the membrane of the muscle. And the membrane of the muscle has these channels. They're called sodium channels. When acetylcholine binds to the sodium channel that's on the membrane of the muscle, it's like open sesame, right? It opens up and sodium rushes in. And when sodium rushes in, it creates this activation, what's called depolarization. That action potential drives down into this blue structure called a transverse tubule, also known as the T tubule. The T stands for transverse. That activation or nerve impulse travels down the transverse tubule, transmits that information to the sarcoplasmic reticulum. And it's the sarcoplasmic reticulum that now releases the calcium. And when the calcium is released, it removes troponin, the staple that's holding in tropomyosin. When the tropomyosin shifts, that active site, or the binding site that's on the actin, is available for the myosin heads to latch onto to create the sliding filament. Okay, so those are important for the physiology of muscle contraction. So there are these two contractile proteins called actin and myosin, and there are these two regulatory proteins. The regulatory proteins are like the on and off switch. That's actin, that's called troponin and tropomyosin. Tropomyosin is this rope-like protein that just blocks the binding sites, and troponin is the staple that holds it in place. And calcium is an important mineral that pulls out the troponin, so the tropomyosin shifts, and now magnetically it's like the myosin heads can find the binding site to allow muscle contraction. Okay, so what we're pointing to here in B is the T-tubule or the transverse tubule. So again, you have your nerve attaching to the muscle. Where they meet is the neuromuscular junction. The gap between the nerve and the muscle is the synaptic cleft. And the synaptic cleft is where that neurotransmitter called acetylcholine moves from the nerve side into the muscle side. And acetylcholine is going to bind on the muscle membrane to that sodium channel. And when it does, the sodium channel opens, sodium rushes in, and you get depolarization. Okay, I also wanted to go over the eye and the eye muscles. So if we're looking at the eye, this is the anterior view of the right eye. So that means that the nose would be here and the left eye would be here. This is the right eye. So if the nose is here, 4 of the muscles are called rectus. There's a medial rectus, and then there's a lateral rectus. And then on top is a superior rectus, and on the bottom it's an inferior rectus. So there's 6 eye muscles, 4 of them have the term rectus in it, and then we just look at the positioning. Since this is medial, we know this is the nose, right? It says the right eye, in anatomical position, this is the right eye. So it's medial rectus, lateral rectus, superior rectus, inferior rectus. The 2 other muscles are called obliques. The one on top is called the superior oblique, and the one on the bottom is called the inferior oblique. So those are the 6 eye muscles. If we look at a model, again, this is the right eye. Here's the nose. So if here's the nose, this would make this, which is on the outside, a lateral rectus. The one on top, superior rectus. You can't quite see the one all the way in the bottom, but the inferior rectus would be there. We could see right here the medial rectus, right? Just the top of it, ever so slightly. Now, those are the 4 rectuses. Where are the 2 obliques? Here's the superior oblique on top. It's going through this little structure called trochlear. It just so happens that the superior oblique is also innervated by a trochlear nerve, which is cranial nerve 4. And then on the bottom, that's the inferior oblique. So superior rectus, lateral rectus. Right there is the medial rectus, superior oblique, and inferior oblique. Those are the eye muscles. Okay, right here is we're pointing to the nasalis, and I wanted to show you here, this is the Zygomaticus Minor, Zygomaticus Major, Buccinator, Rhizorius, Masseter, Orbicularis, Oculi, Orbicularis oris. Okay. Now let's look at the torso. Again, from the larger structure here, it's a little bit easier to see. I outline for you the trapezius muscle. Here's the upper trapezius, the middle trapezius, and the lower traps. So if you look at the fibers, the upper trapezius can elevate the scapula. It shrugs your shoulders up. The middle trapezius, since the fibers go transversely, retract or adduct the scapula. The inferior fibers of the trapezius depress. So elevate is up, depress is down. Make sure you watch my video on ranges of motion. It's important so that you're not just memorizing what muscles do. You have a visual understanding and you can perform them on yourself so you know what they do. So on the right-hand side is the trapezius. When that is dissected or deflected back, now we could see on the left-hand side the rhomboids. Rhomboid minor, rhomboid major. The rhomboids not only adduct the scapula, aka retract the scapula, but they downward rotate it. Think of the scapula as like a steering wheel of the car. So one hand, if I turn it or rotate it, one hand goes up, one hand goes down. If I go the other way in the steering wheel, one hand goes up, one hand goes down. So here, Although when this contracts, the medial part and the inferior angle come up. Remember I said the reference point for rotation is the glenoid cavity. The glenoid fossa goes down. So it adducts the scapula and downward rotates the scapula. It's both of them. With the trapezius dissected, remember here's the spine of the scapula. So you could see the supraspinatus and infraspinatus. Now you can see the deltoid, and on the back side is the posterior deltoid. That's what extends the shoulder. The middle deltoid abducts the shoulder. The anterior deltoid flexes the shoulder, right? The location of the muscle shows you how it's going to move the extremity. What else can we see back here? This muscle running along the spine, it keeps you erect along the spine. So it's called the erector spinae muscle. Here, it's a back muscle. It looks like a back muscle here. It's large, it's immense, but it actually attaches to the front of the shoulder where the bicipital groove is. It's called the Latissimus Dorsi. It goes from the pelvis, the sacrum, the lumbars, the lower sixth thoracic, and then it goes just over the tip right there of the inferior angle of the scapula, tucks under the axilla, under the armpit, and attaches to the front of the humerus at the bicipital groove. Back here is the gluteus maximus. We'll do that when we do the lower extremity, the glutes, the glute maximus. Here's the glute medius. So here, what I labeled B, that's your erector spinae muscle group, the erector spinae. Here is the splenius capitis. This would be the levator scapula. And then it looks like in the front, it's probably pointing to the sternocleidomastoid, right? So these are neck muscles. Splenius capitis, levator scapula, and then in the front on the anterior would be the levator scapula. On the right-hand side here, a close-up, you could see the trapezius. On the left, it's cut. If it wasn't cut, you wouldn't be able to see these deeper muscles. That makes sense, right? Rhomboid minor, rhomboid major, supraspinatus, infraspinatus. Okay, in the front here is the rectus abdominis muscle. Here, superficial, is the pec major. Now, when pec major is deflected and dissected, we can see what's deep to it, which is pec minor. Pec minor goes from the upper ribs to the coracoid process of the scapula. Pec major is going from the clavicle and the sternum, and it too inserts on the bicipital groove. So pec major is going to move the humerus. It'll actually adduct the humerus, and it internally rotates the humerus. We know that because if you see really large people with tight pecs, the arms, let me see if I can catch myself doing this. The arms internally rotate, right? When you see large people at the gym, sometimes they walk like this and their arms swing this way. It's because their pecs are bringing their shoulders forward, and it attaches to the bicipital groove. So it rotates. See if I can hold that in. It rotates so the back of the hand faces you. So when they walk like a gorilla, right? With the back of the hands facing forward instead of walking neutral. So the pec major adducts and it internally rotates the shoulder. When I say shoulder, it means humerus. Okay. All right. So here we could see the rectus abdominis, pec major, pec minor. We can still see the rectus abdominis here. Now these are the obliques. This happens to be the external abdominal oblique. And look at the fibers. They run in a direction as if you're putting your hands in your pocket, right? If your hands are going in your pockets, those are the direction of the fibers. That's the external abdominal oblique. The internal abdominal oblique runs perpendicular to that. It's deep and the fibers are perpendicular to it. So here in this picture, look at these fibers. That would be the internal abdominal oblique. It's deeper. The external abdominal oblique runs in this direction. Okay, so this one I just labeled showing Pec Minor. Pec Major is here. There's your anterior delts. Here is the Pec Minor originating on ribs 3, 4, and 5, and it inserts on the coracoid process. Rectus Abdominis, internal abdominal oblique here. We went through this a few times, so I just labeled this one so you could see. This one is Rhomboid Minor, below it Rhomboid Major, Supraspinatus, Infraspinatus, Erector Spinae, Latissimus Dorsi, posterior delts, upper fibers, middle fibers, lower fibers of the traps, triceps brachii in the back. This I already told you was the Latissimus Dorsi. It originates on the pelvis. The thoracolumbar aponeurosis, because it's all of the lumbar vertebra and the lower 6 thoracic vertebra. It goes up, and where does the Latissimus Dorsi insert? On the bicipital groove. The lats is that large muscle, right? Like, I don't know if I could do it. Let's see if I could stand up here a little bit to show you. But that's when, like, you know, you go like this and it creates the winged effect, you know, that rounded winged effect. It also helps you do pull-ups. It is extending the shoulder, right? Like if you're starting a lawnmower and you're pulling it back, that's the Latissimus Dorsi. If you're doing rowing and you pull the rower back, it's Latissimus Dorsi. If you're doing pull-ups, you're adducting the humerus and extending as it goes back, which is the action of the Latissimus Dorsi. Okay, so that brings that to an end. Let's close that out. And okay, so what we covered in that video, we did a little bit of the sarcomere. Make sure you review again those main parts like the endomysium, sarcolemma, neuromuscular junction, synaptic cleft, T-tubule or transverse tubule, sarcoplasmic reticulum, sarcolemma. Know what actin and myosin are, what the synaptic cleft is, and the muscle physiology, okay, on how calcium is involved, right? You have acetylcholine and calcium. Acetylcholine is released into the synaptic cleft. It binds to the sodium channel. Sodium opens up, sodium rushes in, you get depolarization. That depolarization moves down the transverse tubule. It moves into the sarcoplasmic reticulum. That message stimulates the release of calcium. And that's why calcium is involved in muscle contraction. The calcium removes troponin, tropomyosin shifts, the binding sites on actin become exposed, myosin heads grab onto actin and creates that sliding filament. Okay. We went over some of the facial muscles. We went over some neck muscles. We went over some of the anterior chest muscles and posterior muscles. We went over the concept of minor and major, whether it's Zygomaticus Minor, Zygomaticus Major. You had Pec Major, Pec Minor. That was a unique one where Pec Major was superficial, Pec Minor was deep to it. We did Rhomboid Minor, Rhomboid Major, upper fibers, middle fibers, lower fibers of the traps. Know the difference between the Splenius capitis and Levator Scapula. Okay, they kind of look a little bit similar, but their locations are different. Splenius capitis and make sure you know Splenius capitis, Levator Scapula, and SCM. They're all kind of linear. They go up and down just in different orientations around the neck. We did the eye muscle. We did the 6 eye muscles. 4 were rectus. You had them. If I'm looking at this eye, a medial rectus, lateral rectus, superior rectus, inferior rectus, superior oblique, inferior oblique. Okay. And in terms of movement, if I'm covering my eye, Going this way is the superior rectus. Going down and out is inferior rectus. Let's do it again. Moving up and out is the superior rectus. Down, up and out superior rectus, down and out inferior rectus, straight across lateral rectus, straight in medial rectus. Up and in inferior oblique, down and in superior oblique. So the obliques flip-flop. Even though the superior oblique is above, inferior oblique is below. In terms of function, if I want to test it, if I move the eye up and in, I'm testing the ability of my inferior oblique to function. If I go down and in, I'm checking the superior oblique's function. Again, superior rectus, lateral rectus, inferior rectus, medial rectus, inferior oblique, superior oblique. That's when you're testing the eye muscles. Okay, so that is a little bit of summary of just face, neck, sarcomere, eye, and the next videos that we will move into, one will be of the upper extremity, one will be of the lower extremity. Again, make sure you review your basic ranges of motion, right? Rotation, right cervical rotation, left cervical rotation, cervical flexion, cervical extension, lateral bending or lateral flexion. Then you have to do the shoulder, shoulder abduction, shoulder adduction, external rotation, internal rotation, horizontal adduction, horizontal abduction, scapula elevation, scapula depression, rounding the shoulders, scapula protraction or abduction, scapula adduction or retraction. When the scapulas rotate this way and the glenoid cavities rotate up, that's upward rotation. When the glenoid cavities face down, that's downward rotation. When the scapulas move to the spine, it's adduction. When they move away, abduction. Scapula adduction, scapula abduction, scapula retraction, scapula protraction. Okay, but I do have videos that go over everything, the shoulder, the elbow, the wrist, the fingers. Make sure you review those, okay?